The diagnosis of peptic ulcer disease involves a thorough medical history, physical examination, and a combination of invasive and non-invasive tests. For most patients with uncomplicated peptic ulcer disease, routine laboratory tests are often uninformative. However, blood tests, liver function tests, and levels of amylase and lipase should be evaluated. Serum gastrin levels may be assessed if Zollinger-Ellison syndrome is suspected. Definitive diagnosis of peptic ulcer disease relies on confirmation through endoscopic and/or radiographic imaging. Upper gastrointestinal endoscopy is gold standard and most accurate diagnostic test with sensitivity and specificity up to 90% in diagnosing gastric and duodenal ulcers. Endoscopy provides an opportunity to visualize the ulcer, to determine the presence and degree of active bleeding, and to attempt hemostasis by direct measures if required. During endoscopy, a doctor can do a biopsy, removal of tissue sample for examination under a microscope, to determine if a gastric ulcer is cancerous and help identify the presence of Helicobacter pylori bacteria. Barium swallow. It is indicated when AGT is contraindicated. Gastric or peptic ulcers can be detected on multiple imaging modalities, but are the best evaluated on a double contrast barium upper gastrointestinal study. The classic appearance for a benign gastric ulcer on a double contrast study is more than 2 or 3 mm oval mucosal defect, so-called a crater, or thin gastric folds radiating toward the crater. Testing for Helicobacter pylori infection is essential in all patients with peptic ulcers. Methods for detecting Helicobacter pylori infection are: first one, serologic testing. It detects antibodies to Helicobacter pylori in the blood, but it cannot be used to monitor the success of anti-Helicobacter pylori therapy. Urea breath test. It is high sensitivity and specificity test. It is useful for confirming indication 4 to 6 weeks after completing treatment. It detects radio-labeled carbon dioxide exhaled from the lungs produced by the reaction of Helicobacter pylori RAS with urea. Third one is stool antigen test. It is reliable for initial diagnostics and monitoring post-treatment. Fourth one is endoscopic biopsy. Culture is rarely recommended due to its cost, time requirements, and invasiveness. It indicates in cases of failed eradication therapy or suspected antibiotic resistance. It requires biopsies from 4 to 6 sites to improve diagnostic sensitivity. Gastric ulcers are typically located on lesser craterity between the antrum and fundus, while duodenal ulcers are often in the first part of duodenum. And fifth one is rapid RAS tests, it's so-called RUT. It is considered the diagnostic test of choice during endoscopy